All right, it's just about 5 minutes after 4 here on the Eastern Coast. So why don't we go ahead and get started? My name is Jacob Kirsch, a radiologist in Florida, and pleasure to have you guys join us today for another webinar of NASCI Curious Cases. As usual, this is an open forum, it's a friendly environment, so if anybody has any cases that they want to share with the team, just let me know, and I'll definitely have you share your screen. So why don't we go ahead and start with that? Anybody out there who wants to show a case for us? Any takers? I only have a couple of cases, so if I show mine, it's gonna go very quickly. So if you guys have anything to show, we can do it now or after I show mine. Okay, so I can start. Let me open up my app here. All right, so everybody should be seeing my Dicom viewer. So the first case, let's see, well, let's open this one here. Actually, it's easier if we just do it here because. So this is a 75-year-old male with myeloma presented to the ER with shortness of breath so several months ago, and this is what the CT looks like. So this is a new finding in this patient when compared with prior exams. Patient came in with this at least moderate-sized pericardial effusion. The doctors, the hematologist, thought that it may be related to the patient's underlying disorder. Patient was admitted, and a pericardiocentesis was performed, and patient remained short of breath and had some difficulty at that time breathing. Let me. It's a different patient. Let's see, where is it? Where are my images? Here they are. All right. Any comments on these images? I'm going to stop right there. Again, this is post-pericardiocentesis. You can see the pericardial effusion pretty much resolved. There's maybe trace fluid there. Anything else that you guys see on these images? And I'm stopping here for a reason.
Could you scroll just a tiny bit, please?
Scroll. Of course I can scroll. So here we go. But going back up. So you see there's still some fluid in the pericardium. So it's a little bit thickened, if anything, there, which is probably because of the fluid. Again, going down, I'm going to stop right there.
So is that a little traumatic injury to the ventricular wall?
To the RV here, that little loud pouching by the apex.
Yes.
Yeah, that is correct. So there's a little aneurysm there, and you actually can see here a tiny pocket of gas anterior pericardium, just a non-dependent part, post-procedural. But it seems like they nicked the RV free wall during the pericardiocentesis. Again, every time we poke patients, there's always risks involved with putting needles and instrumentation. Even when we use imaging guidance, pericardiocentesis are done using echo or thoracic ultrasound. And of course, the vast majority of cases are without complication, but not the case here. This was just kind of decided to be looked at and did a short-term follow-up, and this is the next CT scan here. You can see the effusion came back up. If you were to measure that, There it's about above 50 Hounsfield units, so that's not going to be simple fluid. Then you can see at that area that pseudoaneurysm also grew there. It became lobulated, so there's a RV free wall pseudoaneurysm, iatrogenic post-pericardiocentesis, and a hemopericardium associated with it. Patient had to go to the OR for drainage and repair of that right ventricular free wall. So I had never seen a CT scan of a complication post-pericardiocentesis. The first one, hopefully last one that I see as well. Have you guys seen any of these? Prachi, Tariq?
This is fascinating, Jacobo, but I was wondering, was it picked up on the earlier CT? Because it can be hard. I don't know what that CT was done for, the post-pericardiocentesis, the first one.
I know it was just for shortness of breath. It was not prospectively picked up until after the clinicians came down, to review with the reader and gave more history and talked about their suspicion.
Yeah, that's a tricky
Yep.
CT.
Yeah. That's true for sure. This one isn't. This one is pretty obvious. All right, so that's one case. The second case, let's see.
So what did they do with this, Jacobo?
They took him to the OR. They did a surgical repair of the free wall and drained the pericardium again.
Okay.
Patient was pretty sick for a little while after that. May have been related to this, but kind of seems like just a combination of everything: the myeloma and the surgery, and of course the bleed. Everything just the patient took a little bit longer to recover. So this is a patient. Let's see this case. Is a 53-year-old male presented several months ago with fever, shortness of breath, cough. Eventually, these ground glass opacities turned out to be COVID. So this is a patient with just pulmonary COVID here. I think we've seen plenty of these in the last 2 years, so we can recognize them. He came back after resolution of most of the clinical symptoms a few months later with new onset of shortness of breath. And this is a CT that was on at that admission, and you can see it has near completely resolved, if not completely resolved. There's a little bit of atelectasis and some subtle mosaic pattern of attenuation at the lungs, but clearly significantly better. There's some hazy patchy opacities there, but significantly improved when compared with the prior examination. In this case, cardiology was involved. They did an echo on this patient and showed severely depressed ejection fraction, and an MRI was recommended. I'm going to show the MR now, at least a few of the slides, and let's see. So just kind of get the lay of the land here. You can see there's significant calcification here and thickening of the aortic valve. A patient does have aortic bicuspid aortic valve, and that's heavily calcified. We can look at the CT if you guys want, but I think it's pretty clear there, and I would not be lying to you guys. The heart's a little bit on the large side, maybe a tiny bit hypertrophic, and that may be related to the aortic stenosis. Patient was also a candidate for aortic valve replacement, but there was some workup that they wanted to do first. So you can see here the 4-chamber view, just the heart, a little bit hypodynamic, global hypokinesis. You see here again that thickening and calcification of the aortic valve. I'm calling it a calcification because I know it's there, not because of the MR, but you can see a jet of defacing from high velocity, so some aortic stenosis. And again, just the heart is not pumping enough blood. Short axis, you'll see unfortunately they're not in the right order here, but there was global hypokinesis. The patient ejection fraction was measured at 30% on MR as well, so severely depressed. What's very interesting in this patient, and I would like to get your thoughts about it too. I read this case, and those are all the phase contrast for the aortic valve. When you look at the phase sensitive inversion recovery sequences or the late enhancement, there then there's fair nulling of the myocardial signal. But when you look at the short axis, this is where it gets interesting. You can see here focal prominent late enhancement exclusively here at the anterior mitral, anterior papillary muscle. So kind of you can see maybe just a few dots here, but at the head of the papillary muscle, just this very prominent focal LGE. So I guess you have your differential, of course, myocarditis being one of those, and that was part of the suspicion in a patient with recent history of COVID, with acute onset of heart failure with reduced ejection fractions, so about 30%. So that's what I kind of called it on the MR, and the clinicians agreed because we really had no other explanation for the findings. Patient underwent left ventricular cath and coronary cath, didn't see any evidence to suggest that may be an infarct, and it really was done more as part of their workup for potentially an TAVI on this patient with bicuspid aortic valve. That's what they went ahead and also did the cath. So has anyone seen focalized papillary muscle LGE like this in any other settings, either viral myocarditis or even an infarct, etc.?
So Jacobo, I've seen this usually with mitral valve prolapse, heads of papillary muscles, and it's well described in those patients too. So I was wondering if there's any prolapse in this individual.
No, there was none.
Okay. Because that's the one thing that comes to me. Some abnormal strain on the papillary muscles with abnormal mitral valves has been described. But it would be very unusual for myocarditis to be just localized to the papillary muscle.
You can see there the mitral valves looks pretty good. They're moving good. There's no prolapse. There's no or anything to suggest insufficiency or anything yet. So again, it was just kind of funky to have it just focalized there. So anyway, so this patient was considered and treated as COVID myocarditis based on the constellation of findings. And let's see, just for completion's sake. There's the bicuspid aortic valve images, and these are the phase contrast, and you can see there some adding on this sequence that we repeated it. All right, those are my two cases. Anybody else has cases to share? There's a comment in the chat box. Let's see what it says. Papillary fibroblastoma of the mitral valve. It's really within the substance of the papillary muscle, so I highly doubt it. I don't think so. I've never seen a fibroblastoma within the substance of the muscles. They're usually just attached to the endocardial surface of the valve leaflets. All right. Okay, so no more cases, guys? It's gonna be
I can show one quick case.
Let's do that. I'm gonna
so if you want to go, I have one quick one that I can show. It's pretty easy.
I'm gonna make you presenter. Just hit to accept when you get the little window.
Okay.
You should be getting it now. There you go. We can see your screen.
Okay. All right, so hopefully you guys can see it. So this is a 41-year-old female, withheld history, but the images are very telling. So it's a CT that the patient had, and this was actually a known diagnosis, but it was just something I hadn't seen so commonly on imaging. So we have a 2-chamber view, and I particularly want you to look at the mitral valve. So here's what it looks like on a basal short axis view, and this is a 2-chamber view. And if you have any thoughts, go ahead. And this is what the 3D volume rendered image of the mitral valve look like. I don't think it adds much, but these are really the most, and I think the short axis images are probably the most telling here. Any ideas, anyone? What do you think about the mitral valve?
Any of the younger guys on in the chat room there?
Okay, let's see. Would you call this a normal valve, or is there anything abnormal? And if there is, even if you had to describe it, what do you think is the, how would you describe this mitral valve?
I would call it septated, I think, based on just that image, even though that's not the appropriate term to use. But I think that's descriptive enough.
Sure. So it's septated, and you can see instead of having one nice D-shaped orifice, right? So we have this anterior leaflet, posterior leaflet. What we are seeing is like 2 orifices of the mitral valve. So what this is a double orifice mitral valve. This patient had this known diagnosis. I've sometimes seen it with other congenital heart diseases. You can see this and encounter it with some other congenital diseases, but it's fairly uncommon. And it's one of the most striking pictures that I ever have seen. So some of the other things that you can consider is it can be a completely duplicated mitral valve. And the distinction is, as Jacob was saying, it could be septated. So you have a little bridge dividing it. But sometimes when you have a double mitral valve, then what happens is they have separate annuli and separate leaflets with a separate set of papillary muscles. But more commonly, nowadays, you can see people getting mitral valve interventions. So one thing we need to be aware of is this Alfieri stitch. And what they do is, this is a patient who had the Alfieri stitch, and this is not my case, but this is from the internet. So you can see it's pre-op, and the patient has a lot of mitral regurg. But then the surgeon comes in and he does a little bow tie appearance to this. So they kind of coapt this here. So now rather than one orifice, he might have 2 orifices. So this is something you can see in a post-op setting. The one that I showed you was a congenital abnormality. Sometimes the same thing you can see within percutaneous mitral clip. So I just wanted to show this more as a curiosity. It's an interesting case. This was a congenital abnormality and it was a double orifice mitral valve. Here's just another one for completion. This is another patient. It was a cardiac MR, wasn't known at the time. The patient had a history of coarctation and a bicuspid valve. But if you look at the short axis, you can see 2 separate orifices. So on the basal slices, here was one orifice, and this was the other more displaced orifice. So this was another case of a double orifice mitral valve. But I think the CT case was really a clear one. You could see this in the same plane. So just something rare, but you might come across, and more commonly, you're likely to come across somebody who's had an intervention with an Alfieri stitch or so on. So quick one, but any comments from anyone?
Those are very nice pictures, Prachi. Thank you. And yes, now with the mitral clip, they start to look a little bit like that for sure.
Yeah, yeah.
Was that CT? Was that a gated study that you were showing on your?
Yeah, this was a study. Yeah.
Prospective or retrospective?
I don't remember this. I don't think we had retrospective. This was a known diagnosis, so it wasn't even being done for the mitral valve.
Got it.
I can't remember what the indication was. It was a while ago.
Would be nice to see.
Yeah, the movement.
Yeah.
Yeah. Unfortunately, we don't have cine images.
Great case. I haven't seen one of these since fellowship. Nice. Very good. Thank you for that one. Anybody else?
Yeah.
Any cases they want to show, or any questions? Any topic you want to talk about? All right, we have a pretty shy group this month. Well, I guess if that's the case, I want to thank everybody for showing up again. This is a great forum for everybody to share their cases. knowns and unknowns, and you can get different people to give you different opinions on what you're showing. If you don't really know what you're looking at, or it's a rare case, feel free to bring your case and show it to us. Again, thank you for participating. I guess we'll stop right now since there are no more cases, and we'll look forward to seeing you next month. Make sure to go, you can go online to nasci.org and look at the prior videos. We record the session, so you can go back and look at them. There's some really great cases over there. So again, thank you all, and hope to see you soon.
Thank you.
Thanks. Bye-bye.